Hello, everyone. This is Elshaday Belay with OrthoVirginia here in the North region. I am one of the hip and knee reconstructive specialists and excited to join you all today to talk more about hip replacements and really everything you need to know about hip replacement surgery in 2025. I grew up actually in Houston, Texas, but then my family relocated to the DMV area not too long ago, and we've loved coming to the area ever since. I did residency, my orthopedic surgery training at Duke University. I am a Blue Devil and do support them, and they've got a pretty good team this year. So excited about what the tournament looks like. I did fellowship training in hip and knee joint replacement surgery, Hospital for Special Surgery, and it was really a great time for training because, there we performed, over 1,000 cases per year and really gives you good expertise in this area. So jumping right into sort of what, I think we all want to hear about is, what exactly first is the hip joint and why does it hurt? So to understand that, we have to understand the anatomy. And so the hip bony anatomy is composed of the pelvis, the acetabulum or the hip socket, the femoral head, which is or referred to as the ball, so ball and socket joint, and the femur, which is the thigh bone. When someone talks about arthritis or develops arthritis, what we're talking about is the loss of the cartilage space. So it's the space between the ball and the socket. And as bone spurs develop around the hip, that hip becomes more painful. The hip also tends to become shorter over time as you lose space between the ball and the socket, as you can see on the image on the right. That hip has slowly migrated north and is actually a little bit shorter now. Then why exactly is that hip hurting? So there's several causes. We just touched on one, which is arthritis, which is loss of the cartilage surface on the femoral head, the ball. Other problems that can cause hip pain are things like bursitis, which are problems around the outside of the hip, not inside the hip joint, but outside of the hip joint. There's hip impingement, which can happen inside the hip joint, which is a contact point between the labrum and the ball. And then ultimately also the nerves in the lower back can also cause referred hip pain. And there's also a lot of muscle around the hip, which can also be a potential source of pain. So this list here really shows you not all, but some of the many hip conditions that I see on a day-to-day basis. And so when someone comes in and they say they have hip pain, we go through these problems in our minds to sort of understand based on the symptoms, the imaging, what that person has and how we can help. So some of the injuries you can see here, we talked about osteoarthritis, we talked about traumatic injuries. And so we'll see on the next slides, some of the different injuries that can present with. So then when do you need a hip replacement? So one of the most common, if not the most common problems that I see patients who need a hip replacement is what's called osteoarthritis. And this goes back to what we talked about with our anatomy. It's the loss of the cartilage between the ball and the socket. And as that cartilage goes down, the bone becomes more irritable and sensitive and it hurts. And as the bone starts to rub together, that causes pain. And so it often affects one or more joints in that patient. It often starts later in life, over the age of typically somewhere in the 55 range and older. Their features include other areas of the body like hands. You can have arthritis on one side, but not as much on the other side, like this image shows. This patient or person had arthritis on the right hip, but not as much on the left hip. Non-surgical treatment is often the way we start with any problem. So anybody that I see, we always start first with trying to solve the problem without surgery. And if those treatments don't work, then surgery is then the last resort. So non-surgical treatments to reduce the pain, the inflammation, and then ultimately the surgical treatment to remove the osteoarthritis. So other problems that often need a hip replacement is inflammatory arthritis. So things like rheumatoid arthritis, inflammatory arthritis, people who have a history of psoriasis may develop psoriatic arthritis. So these are many different inflammatory arthritis problems where the body has an immune reaction is actually attacking the cartilage and causes early onset arthritis. Patients are often younger, much younger, so in the 30s and 40s as it develops. It typically doesn't affect the fingertips, but it does affect other joints in the hands and knees. But thankfully now with medical treatments, there are fewer patients who ultimately need a replacement because the medications and the medical treatments have gotten so much better over the last decade. And so, but this is again, probably the second most common reason why patients will need a hip replacement. Now, the next common reason is post-traumatic arthritis. So this example is somebody who had a fracture of the pelvis and the acetabulum. So the socket and the pelvis broke. It was fixed several years prior. And then ultimately the hip developed arthritis faster than if that person did not have trauma. And when that trauma then causes arthritis to progress, called post-traumatic arthritis. So broken or fractured bones that cause the surfaces to become uneven. Over time, the friction causes the joint or the cartilage to break down and develop arthritis. And the treatment that's very successful is then replacing that, as the picture shows. Okay, now this is slightly different. This is actually in the acute setting. So somebody that falls or has an injury, a twisting injury or a fall that actually leads to a break, either a stress fracture or a displaced fracture like the image on the right, that patient actually can do well with a hip replacement. Oftentimes with fixing these fractures, it requires intensive rehab and hope that the bone heals, whereas a hip replacement allows the patients to actually be much, much more ambulatory and higher functional outcome at an earlier time. Often the recommended treatment for patients who have these injuries, really anywhere between 55 and 60 years old, or it's a safe treatment and the implants last much longer. One of the last ones we'll cover, again, just one of many reasons why someone may need a hip replacement, is called femoral acetabular impingement. So this is where the hip may not have as much arthritis, the cartilage looks okay, but the bone is actually contacting between the ball and the socket, and they're hitting each other. And that often happens when there's a labral tear, a damage to the labrum, which is a bumper or protection for the hip. And so when there's significant impingement that isn't being resolved with therapy, and as this case example shows, a lot of swelling signaled by the white material that's swelling inside the hip, that patient does very well with hip replacements over time. Again, it's the last resort, so we really try to get those patients recovered with range of motion exercises, strengthening exercises, medications, injections. Ultimately, if it doesn't work and the MRI shows the labrum is damaged, surgery may be necessary. You know someone that has one of these problems, ultimately then when to consider that joint replacement. So these are the questions I ask oftentimes in the office, in clinic. Is the joint pain affecting your ability to sleep? Is it limiting you or stopping you from doing activity, fear or avoidance of activity for that joint pain? Are you taking more medications to keep up with the pain? Is the joint pain affecting your ability to do simple things like walk upstairs, walking uneven ground, or short distances? Those are all telltale signs that you're probably getting close to being ready for a joint replacement. How to prepare for total hip replacement. So you've decided, you've been evaluated, you've been seen, and you know the time is ready. Then what? So first, will you need medical clearances? This is important. So we want to make sure that when we do surgery, that we're doing safe surgery. So oftentimes, if patients have or have not been seen by a cardiologist, not had any recent cardiac workup, we want to make sure your heart is healthy. So we'll have you see your primary care or cardiologist, if you see a cardiologist, to make sure you have a good EKG, to make sure your lab values are within normal parameters so that you can undergo safe surgery. Because although it's less invasive, it's much safer than it was 20 years ago, 15 to 20 years ago, it's still a major surgery. So we want to make sure you're safe. Then we want you to also prepare and schedule outpatient therapy. So have you scheduled therapy? Oftentimes there can be wait times to get into therapy, so we want to make sure you get scheduled well ahead of time before your surgery date. Do you have support at home? So this doesn't need to be someone that lives with you, but do you at least have a family member or friend that can help you on the day of surgery and the day after surgery when you get home? Oftentimes what I recommend for my patients is having somebody, family friend, or friend that can be around at least for the first 2 days at home. Beyond that, most people are able to function well enough at home that they can take care of themselves if they live alone. And then also, obviously important is, do you need to prepare time away from work? So if you're working, you need to prepare at least, often I would say, anywhere from 2 to 4 weeks time away from work, depending on the type of work that you do. People who work home or work at a desk can certainly return to work much quicker than, say, someone who works on their feet or has to lift or carry heavy objects. And then lastly, do you need equipment for rehab? So things like walkers, gait aids we'll touch on, and there's some optional items too, but getting all the equipment that you need before surgery will help you really accelerate your recovery. So these are the 3 most common equipments that I recommend for my patients they really do need. So a walker, for some younger patients may prefer going to crutches, which is acceptable, but a walker or crutch for the first at least few days, anywhere from 2 to 3 days to up to 2 weeks. Then you want to transition to a cane, either a single point, if you look at the very bottom, the single point or 4-point cane, anywhere from 2 to 3 weeks. And then you also want some form of ice. So either ice packs, just traditional ice packs, or an ice machine, at least for the first month after surgery. Other equipments that aren't shown here, but you may have heard about, like bedside commodes, elevated toilet seats, shower chairs, or even hospital beds, are really not as necessary as they once were, because the recovery from hip replacement has become so much more reliable and so much better. They're still optional, so patients who can and want them, we can help them get those items, but they aren't as. Now, focusing on the surgery side. So what is the goal of surgery? So first, it's to eliminate the pain. Second is to return the function to the patient and the quality of life. We do that by increasing your ability to exercise and do activities that you enjoy. That's our goal. That's nothing makes us happier than getting patients back to their activity. And then we also obviously focus in on range of motion, because that allows you to have normal function. So we want you to be able to bend down, tie your shoes, pick things up off the ground, do simple things, as well as the complex activity. So increased range of motion is also vital. How do we do that? So you may have read about or heard other talks that talk about different approaches to the hip. So I use two different approaches, both the anterior approach and the star approach. You may have heard about the anterior approach. It's a good approach. It's a muscle sparing technique, allows us access through the front near the groin. There's generally acceptable lower risk of dislocation. The benefit of that approach is that there is a faster early recovery. So the first 2 to 3 weeks is a little bit faster than the other approach. The star approach, which is called the superior transverse atraumatic approach, goes from the side. It's an MIS, minimally invasive technique that was developed actually in New York by one of the few surgeons who perform this approach in this area. It's a muscle-sparing approach. It's a modified way to perform the historically done posterolateral approach. There's a lower risk of fracture, a lower risk of infection. Ultimately, at 6 weeks, based on evidence, the anterior and star approach have equal outcomes. So it's really about understanding, like I said on the title, one size does not fit all. What is best for you? What is best for you as an individual patient, as opposed to a one-size-fit-all approach? That's my philosophy. So we often have a conversation and understand what's important to you and what unique risk factors you may have, and how do we avoid those risks. So what about technology in hip replacement surgery? So this is something that I'm very passionate about, and it allows us to achieve those goals of surgery like we talked about. So hip navigation. So the VELS hip navigation is one platform that we use for our surgeries. It's often done through the anterior approach, and it's a way that we can accurately plan and perform the surgery by placing the components, the implants, in the right position. So if you put them in the right position with the right size, you can achieve that restored function. The Mako system has been around, and we use that as well for knee surgery and hip surgery. Again, it's a way to perform the surgery to be accurate and precise and allow some bone conserving techniques. So I'll just show some slides just so you understand where that technology came from. So it's actually been around since 2010, so it's not new. Again, not everybody's comfortable with the technology, but it has been around for a long time. And so it's got a really, really good, strong track record of safety and efficiency and effectiveness. So the latest software I use, the most recent and up-to-date latest software, again, it really allows for higher detail and better outcomes in my practice. The overview of how it works. So we get a CT scan. That CT scan then creates a model. Based on that model, we then know for the individual patient what the right size is, how to perform and place the implants in the right position. So I sort of describe this as similar to a GPS. Ultimately, me and I as the surgeon, I'm in control of the implants and as we place them. But this software is a guidance tool and allows us to be precise with where we go. Ultimately, we're still at the wheel. We're still driving that machine. So it's by no means, what you hear about when you hear about robots where the surgeon's in a corner or out for coffee. The surgeon is right there, live and present in surgery, performing the procedure. The VELA system is, again, shown here on this image. So with an anterior hip replacement, we often use x-rays. And as we are taking those x-rays, there are parameters that we set. And so as we are moving the hip components, we actually are getting live feedback of where those implants are being placed. Again, so it's another technology tool that is a way to accurately place those implants. And if you place them in the right position, right size, that patient's going to do well. So we talked about the technology. Ultimately, how do you restore that normal anatomy? That's what we want. So this is an example, one of the goals of surgery, getting the right implant sizing. So we don't want to be too big. We also don't want to be too small. We want the bone to grow onto those implants. And so when we use these technology tools, we can measure very accurately the sizing and placement of those implants. So the socket and the stem as it goes into the body, we're able to accurately measure and know ahead of time before surgery what those sizes are. So we know the right size, and it really is a customized process. Again, this is another example of as we're doing the placement of the acetabular socket. Again, we're very precise with how many millimeters we're positioning and moving the implant so that we can position them in the accurate position. And there's an error rate of about half of a millimeter. So it's really, really, really detailed. And this is, again, the implant as we've placed it. So we can check to verify we hit our target. So our target, for example, was 42 degrees and 24, and we were able to perform that accurately. Leg length. So this is a very important topic in hip replacements, making sure you get the leg length offset in the correct position. So this is a hip replacement done. And if you look at the next slide, as we're performing this, we're able to use those lines that are drawn to make sure that we're restoring the correct leg length. Often with arthritis, the leg and the operative side becomes shorter. So we often tell patients you're going to feel a little bit tight or a little bit longer once we've restored it. But as you get adjusted to your new hip and we've returned it to its normal position, it will then feel normal. And that's the goal. So common questions, common post-operative questions. When can I shower? Oftentimes for my patients, we say that we can shower on day 2. You have a water-resistant dressing, so showering is not a problem. You can go upstairs immediately, and we actually have our therapist on site work with you on stairs on day 0, so that right after surgery. Most patients can return to driving somewhere between 2 to 3 weeks after surgery. Most patients, like I said, based on work, differs based on the type of work that you do. And then returning back to gym and exercise and normal activities, oftentimes right around the 6-week mark after total hip replacement. So thank you for your time, and hopefully we have some time for questions and answers.
Thank you so much, Dr. Belay. Please feel free to leave your questions in the comments now. We will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will get through the ones that we can. So one question that we had come in is, what is the pain relief that is used during surgery and after surgery?
Yes. So pain relief is very important. We want to make sure that obviously we're helping pain get better by replacing the hip, but the surgery recovery does also have some pain. You did have surgery. So we often use a combination, what's called multimodal analgesia. Multimodal meaning we use different types of medications with different properties. So instead of just giving narcotics, heavy dose medications, we use a combination. So ultimately, patients need less narcotics than they once did several years ago. So we use narcotics similar to oxycodone or Dilaudid, in addition to a muscle relaxer, in addition to an NSAID for anti-inflammatory properties, and Tylenol. So that's a common trimodal regimen that I use for my patients. So all 4 of those medications for different purposes, and ultimately it reduces the overall total amount of pain.
Thank you. Where is the incision for the surgery?
So I think I heard that question, where is the incision for surgery? So based on those 2 approaches that I highlighted, for the anterior approach, the incision is essentially directly in front of the thigh. So essentially where if you put your hand in your pocket, your front pocket, right over that area, over the front of the hip, okay? The star approach is directly to the side or where the seam of your pant would be. So next to the side of your pocket. So not behind you in the back pocket, but on the direct side.
Thank you. How long before surgery is the CT scan performed? Is it the same day, a week earlier?
Yeah, an important question. So the CT scan needs to be done within 8 weeks of the surgery date. So if you schedule surgery, for example, in a month from now, you want to have that done as soon as you can, but not earlier. So if you're thinking surgery a year from now, don't do the CT now, do it later. Over time, after 8 weeks, the hip can change, the hip can deteriorate further. So we want to make sure that CT is done closer to the time of surgery.
Thank you. How long does the replaced hip last?
So this is a common question. Hip replacements done today are using implants that have been around for over 30 years. The brand and implants that I use have a track record based on registry data in the United States, the UK, and Australia. And those implants at 30 plus years have a survival of 30 years. Greater than 90% of patients have had no further surgeries or issues with their implants. So there's really a very long track record with the implants that we use today. So specifically with age, historically patients were told that you were too young or couldn't have surgery if you had a bad problem like we talked about. But oftentimes that's not the case anymore. It's really based on what's the best way to return function for that patient.
Thank you. Is hip replacement an outpatient procedure or an inpatient procedure?
It's a complicated answer. So it is by far now a much more commonly done outpatient procedure. Actually, it was initially pushed by insurance companies, and actually Medicare switched it from an inpatient only surgery. So it used to be, 10, 15 years ago, you could only have a surgery done as an inpatient, but now it's actually an outpatient based procedure. So I would say the majority of my procedures are done in the outpatient setting. Now, whether that's done in the surgery center or the hospital, both can be done in an outpatient basis. So if you're in the hospital, undergoing surgery, you're working with a therapist the same day, and you're still able to go home that same day. For patients who have a complex medical history or have cardiac issues or other things that are raised in the workup before surgery, may need some monitoring in the hospital. And so those are the patients that are selected for inpatient stay.
Thank you. Is the arthritis cleaned out from the hip socket when you do a replacement?
That's exactly right. So in the pictures we showed at the beginning, where the hip becomes essentially the loss of the cartilage surfaces and the bone starts to grind away, there's actually also tissue in the hip that becomes irritated. It's called synovial tissue. And this tissue becomes really inflamed. So not only do we remove the arthritis surfaces, we also clean out the synovial tissue, or that tissue that's irritated in the hip.
Thank you. Is it possible to do both hips at one time?
Bilateral hip replacement or knee replacements were much more common about 15 years ago. What we found out was that patients were having a higher rate, things like infection or blood clots, and that was because the surgery and the anesthesia was such a significant amount. So it is really reserved for very severe hip or knee conditions in very healthy and younger individuals. So it's not out of the question, but it has to be done on a case-by-case basis.
Thank you. Do these technologies that you discussed in your presentation work for revisions of existing hip replacement?
They do. It's a complicated answer. It's much more complex. Again, it has to, the replacements, revisions of replacements really shouldn't have to be done by, in my opinion, specialists who train in those areas and are comfortable with this technology, but it can be used.
Thank you. What are the limitations after hip surgery, both short-term and long-term?
Yeah, the short-term limitations are really based on how the patient or individual is progressing. So oftentimes we encourage frequent walking once every 1 to 2 hours during the wake hours, immediately after surgery. Oftentimes between 2 and 3 weeks, patients are now becoming more independent, not using any walking aids, so increasing the amount and distances that they're walking. So in the short term, it's really letting your body guide the limits as to how much you do. Beyond the first month, 4 to 6 weeks, then it's really based on progressing your strength level. So building back the muscle in the hip and in the body. Beyond 6 weeks, things like walking long distances, things like getting back to the golf course and putting and short distance driving is safe to do. Higher level activity like skiing, jumping, jogging even, we don't recommend until at least 12 weeks. That's when the muscle and the bone has really matured after surgery and can withstand some more high impact activity like.
Thank you so much, Dr. Belay. That is all the time that we have for today. Would you like to close?
Yeah, so this is it's been a fantastic event, and I see so many questions coming in that are really very, very good questions. I'm sorry we don't have the time to get to all of them. But if you do have further questions, feel free to sign up for a visit. Happy to discuss this further in person. We have several specialists in different parts of the state as well. If you can't come up to Northern Virginia, we hope you get your care that you need. And it's been a pleasure to be with you today.